Hello students. Welcome to chapter 18, part 2, the lower gastrointestinal tract. So before, in the previous part, we were discussing the esophagus conditions, dysphagia. We spoke about GERD, hiatal hernia. Also, we spoke about the peptic ulcer disease. So for all of you that are having topics that these topics are in your final project, that particular part of the chapter is interesting. Now we're going to focus on the lower gastrointestinal tract, the small intestine disease. These are diseases within the small intestine, generally result in malabsorption because of the impaired function of the organ. Let's remember that the small intestine absorbs sort of all vitamins and minerals and micronutrients, right? So the good standing, the good health of our small intestine is crucial. Malabsorption results from a disturbance in the normal digestive process or absorptive pathway. So we have digestion of micronutrients, right, that are going to be compromised. Also terminal digestion at the brush border mucosa, and also malabsorption, absorption the products of micronutrients, digestion, micronutrients, vitamins and minerals, and water are absorbed across the epithelium of the small intestine into the general or lymphatic circulation. So think about it, right? So you have the absorption immediately going to the circulatory system, but not only that, but also the lymphatic circulation. Chronic deficiency, that's why most of the diseases in our body starts in the gastrointestinal, especially in the small intestine. So the good health of our small intestine is extremely important. Chronic deficiencies of vitamins, minerals, and macronutrients can lead to several forms of anemia: iron, folate, vitamin B12, nutrient-specific diseases, osteopenia, osteoporosis, and other musculoskeletal, endocrine, and nervous system abnormalities. The most common symptoms of malabsorption disorders are chronic diarrhea and steatorrhea. And we know steatorrhea is the fat in the stool, right? We know that. So now, be careful. It's chronic diarrhea. It's not a regular diarrhea. Okay, it has to be chronic. Malabsorption is related to cystic fibrosis and inflammatory bowel disease. So we have diarrhea is usually a symptom of a disease or disorder. Be careful with that. It's a symptom of a disease or disorder rather than a disease itself. However, the author of the book decided to discuss diarrhea in this chapter. So let's see this table 18.2, major malabsorption syndromes. We have the ones related to the defective in the intraluminal digestion. Okay, okay, give me 2 seconds. Okay, so the author is presenting right now the defectives in the intraluminal digestion. Okay, so he divided the malabsorption syndromes in two: the defective of intraluminal digestion and primary mucosal cell abnormalities. Under the first concept, we have defective digestion of fats and proteins, and here he's talking about the pancreatic. So fats is digested by lipase in the pancreas, right? The enzyme lipase, and proteins is protease, okay? And then solubilization of fat as a result of defective bile secretion. Remember that bile, and here the etiology mentions the ileal dysfunction. So we have the small intestine, we have the duodenum, then the ileum, and then the jejunum. And then remember that the bile is secreted by the gallbladder, right, in conjunction with the liver. So we have three organs that are accessory to the gastrointestinal: the liver, the gallbladder, and the pancreas. And each organ has a tube. All of these tubes, the tube from the pancreas, the tube from the liver, and the duct from the gallbladder, all of them then united into the common cyst duct. And this tube goes to the duodenum at the end and in conjunction with the ileum. That's why here they are mentioning the ileal dysfunction, okay? Cessation of bile flow from obstruction or hepatic dysfunction. Okay, now nutrient pre-absorption or modification, bacterial overgrowth, yes, in the small intestine. So as we are studying and describing in detail this chapter, try to visualize the anatomy of the gastrointestinal system. That's very important in order to understand. Now, primary mucosal cell abnormalities, defective terminal digestion, especially the disaccharides deficiency, also known as lacto-intolerance, bacterial overgrowth with brush border damage. Then we have defective epithelial transport, primary bile malabsorption that results from mutation in the ileal bile acid transporter, and then reduced small intestine surface area. And this can cause bariatric cancer, bariatric surgery, caused by surgery, cancer, celiac disease, Crohn's disease, distal ileal resection. So here you have a long list of conditions that are related to these abnormalities, okay? So now, and this is a good table in case you got to present, for example, Crohn's disease or celiac disease or any other, okay. So you can have an extra description more of the terminology, but also the description of the condition. Cystic fibrosis. Let's talk about cystic fibrosis, right? So here in this section, cystic fibrosis and inflammatory bowel disease are two conditions, right, that are happening in the small intestine disease. I want you to understand. So we are going to present first cystic fibrosis and then inflammatory bowel disease, okay, under the small intestines, okay. So cystic fibrosis is a common fatal genetic disease. It's genetic and it's fatal. Although we characterize the disease as a pulmonary disease, yes, commonly we speak about cystic fibrosis whenever we are in the respiratory unit. This is a multi-system disorder that has a profound impact on the GI tract. Okay, so disease process is an autosomal recessive genetic disease, autosomal recessive genetic disease. Chloride ions trapped in cells cause thick, sticky mucus to accumulate. So whenever you're going to see laboratories, okay, your CMP, your comprehensive metabolic panel, you have to double check the levels of chloride. Okay, the abnormal mucus clogs ducts and pathways, leading to multiple complications throughout the organ system, most notably the respiratory and the digestive system. So then we have the cystic fibrosis. We are going to name it right now CF from now on. Symptoms include the following. One is thick mucus in the lungs, okay, and then we have pancreatic insufficiency, okay, and malabsorption, of course, because if we are having a lot of mucus, then all the nutrients are going to be they are not going to be absorbed by the cells, the mucosal of the lining of the gastrointestinal tract, right? Neither the circulatory. Now, liver and gallbladder diseases, clogged bile ducts lead to progressive degeneration of functional liver tissue and elevated sweat chloride concentration, salt depletion through excess sweating. Okay, medical nutrition therapy for cystic fibrosis. So we have to follow 4 standards. It's 1, newborn screening and diagnosis. 2, early initiation of nutrients management. Remember, this is a genetic, so newborn screening and diagnosis is crucial. So 2, early initiation of nutrition management. And also remember, it's a fatal genetic condition, right? So we have to do the screening. Early diagnosis. 3, patient education regarding nutrition needs. And 4, nutrient and pancreatic enzyme replacement as indicated by pancreatic insufficiency, okay? Now, individuals with cystic fibrosis may require significantly more energy and nutrients than dietary recommendation intakes for their age, especially children that are having CF. They need more nutrients than the regular healthy children. Nutrition status assessment, we have to do it every 3 to 6 months. We have to close monitor this. And energy intake adjustment to achieve and maintain normal growth and nutrition status. Now, nutrition therapy for CF includes diet modifications to support nutrient needs, okay, prevent malnutrition, and mitigate CF-related diseases with nutrient-related consequences. So we have to prevent osteoporosis, diabetes, GI complications, behavioral counseling to support healthy dietary habits, and body image and nutrition support, oral or enteral as indicated. One thing that I want to explain here is that if you are not absorbing the macro and micronutrients in the regular way, your mental status is going to change. It's going to suffer. Okay, remember the connection between the gastrointestinal and the brain. Okay, so medical nutrition therapy for cystic fibrosis. These are evidence-based recommendations, especially for children, okay, with cystic fibrosis. They need more calories than the regular children, and that's good to know. You can go through this specific box, okay, especially the ones that are having the final project. Now you're treating pancreatic insufficiency with pancreatic enzyme replacement therapy. So we are having this excessive mucus, right? And we have to treat the pancreatic enzyme deficiency with replacement. But also we have to regularly evaluate the need for or continuation of oral nutrition supplements. So that's good to know. These 2 factors combined, okay, are crucial in cystic fibrosis therapy, okay? The pancreatic replacement and also the oral nutrition supplements. Now, general dietary principles, you have to follow these, include at least 3 meals and 2 to 3 snacks per day, encourage high-fat foods, an additive without dietary restrictions, encourage a variety of whole grain, nuts, fruits, provide nutritional counseling to discuss ideas for high energy boosters, provide high salt nutrition therapy to replace electrolytes loss through sweat, especially to replace chloride. And then when oral intake is inadequate and not expected to improve, probably the healthcare team is going to consider enteral nutrition, nocturnal feedings, etc., etc., etc. So now we have here a case study for cystic fibrosis that I would recommend you to do in order to practice, especially the ones that are going to present cystic fibrosis. Now, let's talk about inflammatory bowel disease. Do you remember I mentioned we were going to cover diseases of the small intestine, and we said one is cystic fibrosis, and then we have inflammatory bowel disease. Under this umbrella, we have 2 conditions, Crohn's and ulcerative colitis, okay? So first, let's present the concept of inflammatory bowel disease. It's a general term that describes chronic inflammation of the GI tract, and the persistent activation of the mucosal immune system against the normal healthy gut flora. Okay, so there is an attack from the immune system to the normal healthy flora. And this may lead to ulceration of the mucosal surface and destruction of segments within the GI tract. Right there, they are telling you the presentation of the Crohn's disease and ulcerative colitis, okay? Because of lesions, portions of the GI tract are not functional, which causes malabsorption, of course. Long-term complication of IBD, which is inflammatory bowel disease, we're going to call it IBD from now on, okay, are osteoporosis, if you are not absorbing the calcium, vitamin D, whatever, iron deficiency anemia, okay, you cannot absorb iron, kidney stones, right, if you cannot process the oxalate, for example, or probably you're having problems with fat. Also, you're going to have certain types of stone in your gallbladder, okay? Relate to malnutrition from chronic malabsorption of macro and micronutrients, okay? Iron deficiency anemia is a particularly common comorbidity for individuals with IBD. Short bowel syndrome may result if repeated surgical removal of parts of the small intestine is necessary due to disease progression. This is very sad. Short bowel syndrome. Okay, so they start removing many parts of the small intestine depending if we are talking about Crohn's or ulcerative colitis, but I think they are talking about Crohn's in this case, and I'm going to explain you why. So imagine if you are having multiple removals, multiple resections from the small bowel, right? At the end, you don't have anything to work in terms of absorption, right? Okay, in addition to genetics, scientists believe that there is a multitude of environmental exposures, beginning at birth, which increase the risk for IBD. Two important exposures during childhood that increase the risk for IBD are the lack of breastfeeding and the overuse of antibiotics. That's some factors that we also assess when we do functional medicine. We assess the patient from the moment of birth, and even before we ask how, if it was a vaginal birth, if it was a C-section, what type of vaccines the patient got, any conditions, the condition of the mother. All these conditions we assess, and we keep a track on the history of the patient from that time to the current time in order to see how the memory of the cells is developing new conditions and comorbidities. Believe it or not, patients in their 50s or 60s or 40s can start developing all these diseases we're talking right now just because the previous history, like we are seeing right now, right, is the lack of breastfeeding and the overuse of antibiotics. That can trigger the inflammatory bowel disease in the adulthood. Exposure in adulthood that increase the risk for IBD includes the use of oral contraceptives and NSAIDs, your Motrin, your aspirin, your ibuprofen, your Advil, suffering from bacterial gastroenteritis or dysbiotic gut microbiota, bacterial gastroenteritis. All of you that are eating every day delivery in the street, that you are not washing your fruits and vegetables appropriately, right? Or maybe you are traveling very frequently to places in which water is many times contaminated. Bacterial gastroenteritis, you are in risk for this. Or dysbiotic gut microbiota, eating a Western diet and smoking. Dysbiotic gut microbiota occurs when you're having too many bacteria in your gastrointestinal system, and also you're having a lot of antibiotics prescribed to cure that particular infection. So you are making an imbalance in your good microbiota, okay? And also Western diet and smoking. Western diet that is high on fats, is high on sugars, right? And smoking. And probably alcohol. So Crohn's disease and ulcerative colitis are the two most common forms of inflammatory bowel disease. Again, Crohn's disease and ulcerative colitis. This idiopathic disease share many symptoms and management strategies, but they differ with regard to their clinical manifestation. Again, they share many symptoms, but they are different in their clinical manifestations. Okay, so that's good to know. Remember that Crohn's and ulcerative colitis are under the umbrella of inflammatory bowel disease. So under the small intestine, we started with cystic fibrosis. Basically it's mucus, right, in the respiratory tract and the GI tract. And then on the other side, we have inflammatory bowel disease. From that umbrella, we have Crohn's and ulcerative colitis. Now, let's check Crohn's disease. Crohn's disease may affect any portion of the GI tract from the esophagus to the anus. Okay, it's from the esophagus to the anus. Any spot, any portion. Most commonly, lesions occur in the ileum and colon. Most commonly in the ileum and colon. You know, DJI, duodenum, jejunum, ileum. So it's the last part of the small intestine, the ileum, and the colon. Symptoms vary and most commonly include abdominal pain, fever, fatigue, anorexia, weight loss, diarrhea. Clients may experience long asymptomatic periods between flare-ups, or they may experience continuous and progressive attacks. This is not a very easy to handle disease. Okay, let me tell you up front. It's a very sad condition. So you have a period of flare-ups, right? Or you have continuous and progressive attacks. And in the middle, you are having abdominal pain, fever, fatigue, anorexia, weight loss, and diarrhea. So there is a point in which the patient doesn't know what to eat. So they don't want to eat. Okay? So complications from chronic inflammation such as bowel obstruction, strictures, fistula, and abscesses may cause severe bowel damage and disability. In addition to the risk mentioned above for IBD, individuals with Jewish ancestry are specifically susceptible to Crohn's disease. And I would say the majority of Jewish patients, okay? So that's something that you need to consider whenever you are working in healthcare. You see your African American, you think about colon cancer risk. You see your Jewish patient, you are going to think about Crohn's disease. You see your Asian patients, you are thinking about osteoporosis. Okay, you see your Latino patients, you are thinking about your diabetes, hypertension, hypercholesterolemia. Okay, so those are the facts that you need to, and you need to master those. So depending on where you are going to be working, okay, so you have to specialize on specific conditions. Okay, okay. Malnutrition and increased micronutrient requirements are common with Crohn's disease. Nutrients needs are high during periods of healing, of course, but compromised nutrient bioavailability is often problematic at the same time. Surgical removal of portions of the GI tract and drug-nutrient interactions further exacerbate malabsorptions and complications. For example, so let's stop here. Let's do critical thinking. These patients are having, problems with malabsorptions, and right now, because this is a problem with the immune system, Okay, this is a problem with the immune system. Now the doctor is going to prescribe long-term corticosteroids, use further increase the risk for osteoporosis. So the doctor prescribed corticosteroids, right, that are going to cause weight gain, are going to lower or making the immune system dormant, putting the patient in risk for infections, and the patient is already having, pain, fever, fatigue, anorexia, blah, blah, blah. Okay, so think about it. It's very difficult to manage. So these medications are going to exacerbate malabsorption and complications. So that was one of the medications, the corticosteroids. Okay, now let's think about ulcerative colitis. So now, in summary, Crohn's can affect any portion of the GI tract from the esophagus to the anus. Now, ulcerative colitis is an inflammatory disease also that is limited to the colon and rectum. It's something different. One is the ileum and the colon, and this one is only the colon and the rectum. Ulcerative colitis. Okay, the way I remember this is that ulcerative colitis starts with a U, and the C is the second letter, the initial letter of the second word, right? So you have UC. Ulcerative colitis is upper colon, means that it starts on the rectum, upper colon, all the way, goes up in the colon, goes up in the colon. And Crohn's disease, okay, I remember the C is cut in any portion. C, cut. The doctor is going to make cuts in different portions of from the esophagus to the anus. Ulcerative colitis is up in the colon. Okay, so it's an inflammatory disease that is limited to the colon and rectum. Symptoms include bloody diarrhea. This for me is the most important differentiator, because you don't have bloody diarrhea in Crohn's disease. So bloody diarrhea, abdominal pain, nausea, vomiting, weight loss, and fever. Okay? So the inflammation does not skip sections of the bowel like in Crohn's. Rather, it's a progressive form from the anus. Severe complications associated with ulcerative colitis are megacolon and disease advancement to the point of require totally colectomy. And megacolon is the abnormally enlarged colon is here, okay? Abnormally enlarged colon. So with the exception of iron deficiency, anemia, and vitamin K deficiency, ulcerative colitis is not associated with as many micronutrient deficiencies as Crohn's disease because of the location of the inflammation. Remember that the colon only absorbs water, and this is ulcerative colitis from the colon and the rectum. And Crohn's is the ileum. Is we have a lot of absorption going on there, macro and micronutrients. However, as pain or inflammation increase, food intake decreases and additional deficiencies may occur. Medical nutrition therapy for inflammatory bowel disease. You have the healthcare team will explore a range of feeding modes, including enteral or parental if necessary, to achieve the nutrition care that is necessary. So now we have principles of continuing dietary management in IBD, inflammatory bowel disease, include the following. We're going to go there before the table. Look at this picture. This graphic is excellent. You can see on the left side, this is the Crohn's disease, and you can see is the condition is happening in any portion from the esophagus to the colon, right, to the anus. Here there is a red bar, then it's skipping a portion, then it's another one, okay? So if, as I was explaining before, if the patient needs to have resection, imagine they are resecting this red part here. They are doing anastomosis, And then they are resecting another part here, which includes the appendix, okay? They are going to resect here and another one here. So it's going to be very difficult to manage, right? Especially if this is happening in the esophagus area. And now ulcerative colitis, you see, is the rectum and the part of the colon. Okay, here, okay. Ulcerative colitis, okay. Okay, let's go back to the principles of continuing dietary management of IBD includes the following. So let me, okay, I'm gonna highlight this way. So let's see. So I think there's a couple of people that got the Crohn's disease for the project. So you have manifestations common to both inflammatory disease. This is the table this is the part that I like the most because it's giving you the common to both inflammatory bowel diseases and also specific to each condition. So common is going to be the genetic part. The intestinal gut flora plays a role, but there is no specific microbe. Claro, there is no specific microbe that is causing the condition because it's the immune system and is sometimes genetic. So it's linked to inappropriate T cell activation, the immune system, or too little control by regulatory T lymphocytes, also immune system. Now, symptoms, abdominal pain, diarrhea, and weight loss in both cases, complications, malnutrition, osteoporosis, dermatitis, ocular symptoms, liver and gallbladder complications, and kidney stones. Now, let's see specific to each condition. In ulcerative colitis, we have former smokers are at higher risk than current smokers and those that have never smoked. While in Crohn's is Jewish ancestry and smoking. Okay. Now, so make the difference there. Okay. We are not saying that Jewish are not getting ulcerative colitis, but it's most common in that they are going to have Crohn's disease. Now, bowel region affected, the ileum and the colon, and here is the colon only. Distribution, skip lesions, here is continuous. Then inflammation and ulceration, mucosa and all underlying tissue layers, mucosa and submucosa layers only. Here you had lesions that are in the ileum, here is not. Response to surgery, poor to fair, because imagine they are doing this resection multiple times. And in ulcerative colitis is good because it's continuous, so they are going to remove only one part and that's it. Long-term complications in terms of ulcerative colitis, perforation and toxic megacolon. These patients also have a high risk for cancer. And in terms of Crohn's, fibrosis strictures, fistula to other organs. Why? Because this condition is going to affect the mucosa and all underlying tissue layers. That's why they are having risk for fistulas, okay? While ulcerative colitis is the mucosa and submucosa layers only, okay? So you see there are more complications in Crohn's than ulcerative colitis. During periods of inflammation, use enteral nutrition support if necessary. Also, GI function, do not tolerate enteral feeds, use parental nutrition support in the case enteral is not well tolerated. Progress to low fat, high protein, high calorie, small frequent meals when returning to a normal diet as tolerated. The diet should be low in fiber only during acute attacks with strictures. Otherwise, the client can gradually increase fiber intake. Vitamin and mineral supplementation should include vitamin D, C, calcium, magnesium, folate, and iron. All of these are absorbed in the intestines. Now, during periods of remission, meet energy and protein needs that are specific for weight and replenish nutrient stores. In the presence of hyperoxaluria, individuals with Crohn's disease should avoid foods that are high in oxalates, right? Increase antioxidant intake, oxalate because of the risk of kidney stones, right? Increase antioxidant intake and consider supplementation with omega-3 fatty acids that are anti-inflammatory. Omega-3 fatty acids, especially if you get a combination of omega-3, omega-6, and omega-9, they are good for anti-inflammatory. And glutamine. Consider the use of probiotics and prebiotics because already the microbiota is compromised. So we need to create some balance if the body, the immune system, and the condition of the patient allow us. We are going to do the most of our possibilities, right? We are going to prescribe the best probiotics and prebiotics. So we hope to get good results. Let's move to diarrhea. Typically, it's not a disease of the small or large intestine, but rather a symptom or result of another underlying condition. In some cases, diarrhea may result from intolerance to specific foods or nutrients, such as an intolerance, lactose intolerance, or acute food poisoning from a specific foodborne organism or toxin, as we saw in chapter 13. We have bacteria like Campylobacter, Clostridium, Escherichia, Listeria, blah, blah, blah. So chronic diarrhea is the one lasting more than 4 weeks. It's a significant cause of global mortality. Of course, you are losing a lot of electrolytes, vitamins, minerals, right? And also you become dehydrated, especially for children less than 5 years old and the elderly more than 70 years old. So this is a problem. Rehydration and restoring electrolytes and acid-base balance are critical elements for recovery. Some individuals are able to restore euhydration, and we know that this term refers to the regular hydration in the body, by drinking oral rehydration solutions as Pedialyte, Ceralite, Rehydratolite. Other may require intravenous fluid and electrolytes replacement to regain balance. And as soon as the client tolerates it, he or she should resume a regular refeeding schedule to avoid malnutrition. So here we have to pay attention to the refeeding syndrome. It's a potentially fatal metabolic disturbance that involves fluid and electrolyte imbalance, and that can result in cardiac failure. Again, refeeding syndrome is a potentially fatal metabolic disturbance that involves fluid and electrolyte imbalance, and that can result in cardiac failure. NCLEX alert, safety, okay? When you see refeeding syndrome in your exam. And also, that's good to know, NCLEX alert, you know, chronic diarrhea is defined as a condition that lasts more than 4 weeks, right? And we have to be careful with children less than 5 years and elderly more than 70 years. Okay, so let's stop here. When we come back, we are going to talk about the large intestine conditions. Thank you.